Welcome to AETCM. Today we'll be discussing about a case of a 25-year-old male with no known comorbidities who came to the ER with complaints of hemoptysis since yesterday. Patient had the first episode early in the morning when the patient coughed, following which he had an episode of hemoptysis with 100 ml of fresh blood. Following which the second episode happened in the evening with episode of 250 ml of fresh blood post coughing. Patient had a total of 4 episodes before arriving to the ER. Patient also had complaints of intermittent dry cough over the past year, and patient had complaints of unintentional loss of weight. There were no complaints of fever, shortness of breath, chest congestion, rhinorrhea, or sore throat. Patient's mother gave a history of some cardiac issue when the patient was an infant, but the records were not available. No history of exposure to dust or patients with TB and pneumonia. No history of smoking. No history of recent trauma, or no history of malignancy in the family. Patient's sister had a history of pulmonary tuberculosis 3 years back, which was treated with 6 months of ATT and was Putin negative post that. Patient had recent history of travel
Who
to
had TB? Mother.
Sister. Own sister. Patient had a history of travel to the Gulf countries with frequent travels over the past 2 years. So my case is a 25-year-old male with no known comorbs who's come with complaints of 4 episodes of hemoptysis since yesterday. My differentials based on the age and the locality would be primarily pulmonary tuberculosis, given the patient's history of hemoptysis with unintentional loss of weight, and a family member having being diagnosed with pulmonary tuberculosis recently. The second differentials would be congenital bronchiectasis, given the age of the patient and the history of and the complaints of hemoptysis. Although the patient did not have any symptoms of sinusitis or did not mention any particular symptoms of infertility, documented history of infertility before, the other less likely diagnosis could have been pulmonary embolism, given the sudden onset of the symptoms. But patient did, and the infant history of some cardiac illness in the patient. But the patient did not give any history of surgeries or immobilization recently. The other differentials considered were Goodpasture syndrome and verginous granulomatosis, which had to be evaluated further on, and any history of trauma which the patient did not realize, which will be evaluated later. So moving on to the inspection of the respiratory system, bilateral symmetrical chest walls with no spinal or sternal abnormalities. Trachea appeared to be central. Chest movements were equal with no shoulder drooping or chest retractions, no scars or sinuses. On palpation, inspectory findings were confirmed. Apical impulses were located in the left 5th intercostal space, half an inch medial to the midclavicular line, and the vocal parameters were equal on both sides. Percussion was not done, given the history of hemoptysis. Auscultation, bilateral air entry was present, normal vesicular breath sounds. On arrival to the ER, ABG was done, which was normal, and the point of care CBC was normal, CRP was 0.5. Vitally, patient saturation was 99% in room air, heart rate of 64, a BP of 120 by 90 millimeters mercury, and a respiratory rate of 20 per minute. Patient did not have any active episodes in the ER. So firstly, we ruled out, we had to confirm if it was hemoptysis or pseudo hemoptysis or hematemesis. But given the history of hemoptysis being followed by cough, and the color of the blood was frank red, mixed with sputum, so we confirmed it to be a case of hemoptysis. So, and post that we put the patient on NPO. Since the amount of blood was quantified to be around within 200 ml, we classified this as moderate hemoptysis. Okay. So we started the hemoptysis workup for the patient. Labs were sent. CBC showed normal hemoglobin with serial monitoring showing no hemoglobin drop, which ruled out any active bleeding in the patient. Platelets were normal, which ruled out any platelet thrombocytopenia. And the total counts and CRP and procal were normal, which initially ruled out infection. The coagulation profile was normal, which ruled out congenital bleeding abnormalities. Urine routine was normal, with no blood or casts present, which provisionally ruled out Wegener's and good pastures. Chest X-ray on grossly looked normal, with no particular mass or cavity, which ruled out malignancy or lung abscess. And sputum was sent for AFB cultures, gene expert, and results were awaited at that point. A screening echo was done to rule out any cardiac abnormalities or mitral stenosis.
Okay.
D-dimer was sent, which is again
mitral stenosis will produce hemoptysis.
Vegetation and clot.
Yes, told. That's why I'm telling. Pulmonary edema is one reason. Other than that, mitral stenosis, what you told is correct. Mitral stenosis can produce bronchiectasis, hemoptysis, everything due to history taken was correct. I'm not telling it is wrong. But there is a reason for that. You cannot blindly ask questions. We should know why we are asking questions. There is a reason. What happens in mitral stenosis? Which chamber will enlarge?
Left atrium.
Left atrium. Left atrium enlarges which process on which bronchus? Which bronchus? Enlarge and process on the left main bronchus. So left side bronchiectasis is very common. Left-sided infections are very common. That is the late stage of mitral stenosis or mitral regurgitation. That is because of the compression of the left bronchus by the left atrium. Okay. That can happen. And pulmonary, like they told, pulmonary edema is one of the reason. Pulmonary hypertension is the third reason. So mitral stenosis can have a lot of hemoptysis.
Okay. And the D-dimer was sent was negative, which initially ruled out pulmonary embolism, and the Wells score was just 1. So going by the common mnemonic for causes of hemoptysis, it was battle camp. So we B for bronchiectasis, A for AV malformations, T for tumor, second T for tuberculosis, L for lung abscess, E for pulmonary embolism, C for coagulation disorders, A for autoimmune disorders like good pastures and Wegener's, M for mitral stenosis, and P for pneumonia, could be bacterial or fungal. Patient had a
bacterial pneumonia commonly present with red currant jelly sputum.
Klebsiella. CECT was done outside before arriving to Amrita, and the CECT on gross look ruled out bronchiectasis or abscess or alveolar hemorrhages because there were no ground glassing or interseptal thickening or any cavities. So we put the patient on NPO and we proceeded with a CT iotogram because the outside CECT had mentioned that there was query involvement of a pulmonary arterial system in the right lower lobe. So the CT iotogram done showed a ground glassing opacity in the right lower lobe with a D10 level intercostal artery feeder towards it, which suggested a pulmonary sequestration. We proceeded with the bronchoscopy, which did not show active bleeding in there. There was the presence of clots.
So this comes under AV malformation.
Yes, sir. So that was done. Patient was kept in NPO for the time being, and an interventional radiology consult was taken.
What they'll do?
Transarterial embolization of the feeders. They embolized 2 of the feeders, and once the current hemoptysis has settled for now, patient will be posted up for lobectomy in the future.
So what should be the position of patient in ER?
Sir, the affected lung has to be towards, like patient has to lie on the affected side of the lung.
That is what to reduce the cough, breathing. To drain, what is the ideal position? On the opposite side. If you keep it on the same side, there is a chance of accumulation of blood there. But to drain, if the patient is conscious, better to keep it on the opposite side. But if the patient is having pain, all these things, you can ask the patient to lie down on the same side. But there is a chance of accumulation of blood and mucous plug obstruction in that area. That we have to decide. Clinically, we have to see the patient and decide.
Yes.
Okay. Now, finally, what happened to this patient?
So, patient is now being worked up for.
What is the reason for AV malformation? Genetical problem.
Genetical, most because the All other parameters were normal when being tested. So we initially even worked up for a Rasmussen aneurysm, given the history of TB.
What is Rasmussen's aneurysm? What is Rasmussen's aneurysm? We are told about Rasmussen's, that's why I'm asking.
Post TB sequelae, there will be a cavity where the bronchial artery is involved.
So bronchial artery is going through the cavity. Suddenly it can rupture inside the cavity and a lot of blood will come out.
Yes.
So that is a common thing occur in TB.
Yes. Okay. So right now it's being worked up for lobectomy at a future date.
Okay. So tell something about bronchiectasis. In general.
So bronchiectasis is
young patient coming with bronchiectasis, what are the things you have to rule out?
So
this we have ruled out AV malformation, that is corrected.
Yes, so congenital cause of bronchiectasis alpha-1 antitrypsin deficiency. So there could be cartilaginous or Young syndrome. So the triads have to be ruled out. Patient did not have any chronic sinusitis. X-ray did not show situs inversus. And there was no documented history of infertility.
What is the difference between situs inversus and dextrocardia?
Every viscera.
Everything will be on the opposite side in situs inversus. Dextrocardia, only heart will be on the right.
Yes, sir. So those are the congenital cause. There is no history of smoking as such, which could have caused bronchitis in the later section. And
so you have to rule out sinusitis, you have to rule out pharyngitis, you have to rule out bronchiectasis, you have to rule out infertility.
Yes, sir.
So many things has to be ruled out. Yes, family history is also should be taken.
Yes, sir.
Okay. Anything else you want to add? It's a case where we have diagnosed it as a AV malformation. That is not very common. That's all. Normally when we see a bronchiectasis, we always think that tuberculosis is the most common cause. That is the most common cause. And some other necrotizing pneumonias like Klebsiella, Pseudomonas,
all
Staphylococcus.
sputum and bowel cultures are all
everything is.
That was our initial working diagnosis until we ruled that out.
If you don't make a diagnosis here properly, finally the patient will end up with the treatment of anti-tubercular drug. That is a problem. We may assume that this also may be due to tuberculosis. Luckily, he has got a diagnosis, and we can easily correct it. Anything else? Okay, thank you. AV malformation.